Welcome to ERAD's second CPD event for the year, being presented by our three presenters this evening. As advertised, we have Dr. Loina, our specialist physician from the Vicha Hospital, Dr. Joseph Kabongo from ERAD Radiology, specialist radiologist, and Dr. Emmanuel Thobejane, Neurosurgeon and Pain Specialist from the Vicha Hospital as well. We hope that you will enjoy the topic that is being presented, which is cerebral vascular accidents, known simply as stroke events, and that everyone will learn through the experience with us. My name is Aleta Land. I am the Chief Radiographer for ERAD Radiology. So our first presenter is Dr. Loina, our specialist physician. She's going to kick up everything from a clinical perspective. As mentioned, she is the specialist physician at Vicha Private Hospital in Walvis Bay. Originally from Tanzania, she has studied medicine abroad in Russia and earned her qualifications as follows: a doctorate in medicine at the Medical University in Novgorod, Russia. Yes, and then a master's in medicine from the same university, as well as the University of Dar es Salaam in Tanzania. She ventured to Namibia and worked at the Windhoek Central Hospital, after which she moved to Oshakati to be a physician at the Oshakati State Hospital as well. But then since 2020, she has been the attending specialist physician at the Vicha Private Hospital. She is involved in a lot of medical missions, donating her time and expertise to clinics and hospitals. And through this work, she travels to Lüderitz, Hentisbay, Omaruru, and Grootfontein, which she says she enjoys a lot. She enjoys traveling, cooking, and spending time with her family as well. Okay, so now over to Dr. Loina.
Good evening, ladies and gentlemen. I'm going to present today about cardiovascular accident. The objective for the presentation, the scope of the problem, life-saving acute treatment of the more I'm going to base on ischemic stroke, current primary and individual secondary prevention. I think you agree with me that the cardiovascular accident is a global problem. It's a huge problem in the public sector, public health sector. It's a catastrophic medical emergency that can happen to the person. Consider the outcome. Actually, it's among highest cause of death and disability among survivors. I'm starting by giving the definition of what is cardiovascular accident. What is happening there? It happens when there's a blockage or there's a rupture of the blood vessels. Before I move forward, the cardiovascular accident stroke usually is going shoulder to shoulder with a TIA. The TIA is the same as a cardiovascular, but thankfully here the symptoms improved and there's no restriction on diffusion MRI. So that is the difference. That the things happen. It should be resolved in 1 hour. Previously it was 24 hours, and there's no evidence anyway. So that is the definition that I explained already. So the sudden onset of neurological deficit that is caused by those, either blockage of the throat or from the rupture of the blood, as you see. Then in our daily practice, I'm sure that majority of the stroke that we see, they are ischemic, 80 to 87% there. Then they can come to the bleed, where the 10% goes to the intercerebral hemorrhage, and the minority is going to the subarachnoid hemorrhage. There's a mechanism so that we can approach our patient proper. We should know the mechanism. What happened when someone have got a stroke. But I'm not going to go deeper on that. I will try to put it in pieces so that we can understand a little bit each other. As we know, we have ischemic stroke. What happened in ischemic stroke is a thromboembolic phenomenon. Either there is embolytic or they are thrombotic. So there's a condition that can lead to the thrombotic. There's a condition that can lead to embolic. Most of the embolic, they come from the heart. As we know, usually AFib is the only leading law for causing embolic phenomenon. We have left ventricle aneurysm as well, and of course the mechanical valve replacement, especially mitral one. If you go again for thrombotic, those are you are talking about the vessels, the big vessel occlusion and the small vessel occlusion. And from the larger vessel occlusion, usually internal carotid is more common, and the basilar vascular also is the common. So we know also we have the bleed here. We have intracranial bleeding, intercerebral hemorrhage, which usually is secondary to the factor risk that you failed to control previous. On the reading of it is, we know it's a hypertension. That is the reading one. Then you go for those are modifiable: diabetes, hypertension, dyslipidemia, smoking, and etc. And they are non-modifiable, that is the age and if you are men. And if we go for the subarachnoid hemorrhage, that is usually an aneurysm, and the main cause is a blunt trauma. But also IV malformation also can lead to it. Prevalence of stroke, we are counting from our continent, Africa. I think we are a little bit also on leading, on top of reading, because 100,000 people, 316, they are suffering, they got ERAD stroke. And the occurrence of the stroke in sub-Saharan Africa is 2 to 25%. So if you check, we are still on top if we compare with other continents. And when you get a stroke, it means there's the possibility of, in 1 year or 5 years, there's a possibility of getting another one. So it's like when you get a stroke, one, you are like opening door for another one. As I said, you can find in brochures and for advertising. So every individual know how to detect it. Another one is we perform in emergency room, but that is not in news nowadays. We are calling the erosion. That you look for the loss of consciousness of the patient, seizure activity, although nowadays that seizure activity is not on the recognition, it's out. Somatic weakness, you see again the weakness of the face, arm and the leg. You check speech and visual disturbance. But the minor on Loja is incorporated with Glasgow Coma Scale and valid for identified TIA and stroke, and also it identifies stroke mimicry. Like when someone coming with a hypoglycemia, everyone support, all physician support is a national institution has a stroke scale, NIHSS, where it's based also a little bit like Eloxia in a certain way. You look for consciousness, motor, sensory, language, attention. And as I say, the benefits, what is the benefit of it? Because we all accept, all physicians worldwide, they support. It is a simplicity, rapid to use. However, does assess for truncal, ataxia, gait, vertical gaze pass, nystagmus, and others. And it got a very low score on the patient with posterior circulatory block occlusion than the anterior one. So now the diagnosis of stroke. Stroke diagnosis actually is the clinical. The image is just to support what you pick up on investigating your patient. So the main thing why we are doing image like CT, because we wanted to rule out a breed. Because those two stroke, the management is different. So we have MRI, we have CT, those things, everything Dr. Kabongo will go through. There's a head and neck where you want to see where the source of thrombosis. So those are the things, cardiac evaluation, to look for thrombosis as well. You do echo, you want to see where it is. Access of atherosclerosis, of course, and the risk of the risk factor. So you want to check A1C, you do repeat panel, smoking history, hypertension control, and physical activities together with that. What is new in acute stroke care? Thrombosis, thromboectomy, intracranial hemorrhage. Not every patient is a candidate for the thrombosis. So we have criteria for it. First of all, the patient should, in the CT, it should show that there's no bleed. And as we know that the CT, when you do CT on early stage, you want to pick up anything. It will be absolutely normal CT, but it's not like there's no stroke. That's why we say stroke is a clinical. So it helps you to say now you can go further if the patient meets criteria. So the patient should not bleed on CT, should be age above 18, and the timing, that is the key, that it should be less than 4 or 4.5 hours. Other indication is when there is already neurological deficit, which is not resolving as time goes. So what is the contraindication now? The contraindication, it's based on history taking. The patient, if is not able to speak, you need to communicate with the family. you ask history. Did the patient have previous MI 3 months? Did the patient have any spine surgery, any malignance recent? Is the patient have recent head trauma? Is the patient on any anticoagulation treatment? And of course, on the clinical presentation, what we see, we look for how the patient presented, the patient conversing. On hematological, we look for the protein profile. Like we want to look for how the platelet is, and of course the CT there. And then on the clinical presentation, also we look for the NIH scales. It's very so important to see did the patient fit for the thrombolysis, because if the patient is having the score of above 25, that is not a candidate. So thrombosis, the time is brain. Why we are saying the time is brain? If you time nicely, then you can restore the result. It can be better. If the timing on thrombosis, you time nice, the result it will be better because few brain cells is going to be there. And we have also door to needle. What is mean door to needle? Door to needle, it means when the patient coming from with the emergency service on that door, and here already you got a call that there's a patient coming. So on the door patient, you already inform CT people. There is a training nurse, neuro nurse who well trained. There's a doctor, there, physician, there's a neurologist if the setting is allowed. And of course, also you have thrombosis. So the time is, that is time to needle, it should be shorter. The more you minimize time, the better outcome. And it's for every 15 minutes that you reduce on time to needle, it means that you minimize the mortality for 5%, hospital mortality. So preparation is the key. What it means? It means when the patient is already on the hospital setting, we need to do little as possible, not a lot, to increase that time. That is at the hospital, right? And much when the patient is on the way. But by American Heart Association, the best is practice strategic to reduce door to needle time, such as the EMS, emergency medical service. They give notification to the hospital that we bring rapid laboratory already. You need to check for the you check for the sugar, you check for the lipid, you check for the protein profile, platelet FBC to know that everything is fine. Direct patient go to the city, and everything goes quick. Then you prepare your thrombolytic agent there. And if it's possible, they are advising to be already in the needle, not to start looking where's the pharmacy. Is there any alternative to a template? Yes, we have teneplate. That is a modified version of a template. It got high fibrin specifics, and the half-life is higher. And of course, also as a template, also you can borrow us. A template vs teneplate. That is the study 2020. So study that observed the level of efficacy and safety between a template and a teneplate. Results show compatible efficacy and safety of teneplate with a template when it's given on the exact time and with the required dose, which is 0.25 per kg. According to the stroke guideline, regardless the age of the severity, patient or presented with acute ischemic stroke, 4 hours interval, known onset should be either started for those two. There's another study is extend the trial. So they are saying that teneplate at 0.25 showed higher rate of reperfusion and improvement in 90 days since functionally, since the stroke. With larger, that is applicable more when there's a larger occlusion is involved. And also you can use that. The patient with larger vessels occlusion, we are encouraging also to go for thromboectomy. So you can go for thrombolysis, then patient can still, without wasting time, can go for the procedure. So they can get all of them. So different in incidence of recovery to independent function was not significant. That is what from that one. Also, there was no difference in risk, symptomatic, asymptomatic, intracranial hemorrhage, and others. So implication for teneplate. It's very easy to use and it's faster. And it minimizes the time to be on the emergency. I think that is even for a tablet is like that. So current clinical recommendation is 0.25, but there's still research ongoing, it's still conducted. But in case of the stroke that you don't know the time. So FREA vs ischemic region. FREA is a fluid attenuated invasion recovery. So a significant amount of stroke that happened during sleep occurred during the stroke. When the patient sleep, usually wake up with a stroke, it happened on the last minutes that patient wake up. So that is a window time for the thrombolysis. So this can be visualized through diffuse weighted image. So that is the FREA is compared with the ischemic brain lesion. This mismatch helped to predict whether the onset of the stroke it was within the time that we require. Onset of time unknown, that is including wake-up stroke. There's a work trial. It was found in patients treated with a tablet who has a distinct MRI signature profile image, indicative of 4 hours CC recognition was associated with good function outcome at 90 days. Target mismatch between CT and MRI perfusion. Usage of a tablet was associated with a good outcome when there was evidence of perfusion mismatch only in the diffuse weighted image. There were no significant difference in patients without a perfusion mismatch. According to the guideline, patients with acute ischemic stroke, irrespective of age or stroke severity, who were seen 4.5 hours early should be considered for thrombolysis with a tablet if the treatment can be started between that time and 9 hours of known onset or within 9 hours of the midpoint of sleep when they have worked with the symptom. And there is evidence from the CT or MRI perfusion or MRI FREA mismatch of the potential subvegetable brain tissue and should be considered regardless of whether they have larger vessels occlusion or require mechanical thromboectomy. Mechanical thrombectomy MT with the best medical management is recommended in adults with anterior circulation larger vessels occlusion related to acute ischemic stroke, which presented between 6 to 24 hours from the last known time when on baseline function. Fulfilling down and refuse 3 criteria: IV thrombolysis plus mechanical thromboectomy recommended in patients with larger vessels occlusion related ischemic stroke as soon as possible as the patient arrives to the hospital. Mechanical thrombosis and best medical management is indicated for the patient more than 8 years with larger vessels occlusion related acute ischemic stroke presented less than 6 hours of the symptoms onset. In cases of larger vessel occlusion related acute ischemic, without extensive evidence of impact, mechanical thrombosis is recommended within 6 hours of window. Advanced image for the patient beyond 6 hours of last known.
Dr. Loina for that presentation. Next, we have the presentation by Dr. Kabongo, a specialist radiologist for ERAD radiology. Quick introduction about Dr. Kabongo. Dr. Kabongo is a diagnostic and interventional radiologist hailing from who did his studies at Stellenbosch University and holds the esteemed title of Fellow of the College of Medicine of South Africa and European Diploma in Neuroradiology, with expertise spanning across various modalities, including conventional radiology, computer tomography, magnetic resonance imaging, mammography, and nuclear medicine PET-CT. Dr. Kabongo is adapted both performing and interpreting a wide range of diagnostic imaging procedures, from ultrasound and fluoroscopy to interventional radiology. As a consultant radiologist, Dr. Kabongo brings to the table a wealth of clinical knowledge coupled with relentless drive to tackle new challenges and stay abreast of the latest advancement in his field. And this I can attest to. Dr. Kabongo's expertise extends to specialized areas such as neuroradiology, cardiovascular imaging, whole body imaging under MRI, and more advanced imaging techniques, ensuring comprehensive patient care and accurate diagnosis. He is fluent both in French and English, as he does come from the Democratic Republic of the Congo. Dr. Kabongo possesses excellent communication skills, making him adapt at effectively interacting with patients and colleagues in a multicultural environment. With a passion for delivering high quality patient care and a commitment to professional excellence, Dr. Kabongo is poised to make significant contributions to the field of radiology, especially in the community of Walvis Bay, if I can say so. So up next, I'd like to bring forward Dr. Kabongo.
Good evening and welcome to our symposium. I would like just to do some adjustment to the slide before we proceed. Okay, so this is the agenda that we'll go through during my presentation. So with the introduction, imaging in acute stroke, evidence-based guideline. We'll look at the imaging paradigm, CT protocols, MR protocols, approach to interpreting a code stroke, as we told earlier about Bologna, and also optimizing the imaging flow in acute stroke in our hospital or practices. And lastly, we will look at the stroke mix, and then there'll be a take-home message. There'll be a quiz. So please, if you have your phone, you can just go to slides, slio.com. Just take your phone and go to that. Or you can scan the QR code. Are you all set? Okay. If you're all set, then I'll proceed. The question will pop up on that phone, so just keep that screen on. So, introduction. As we saw, Bologna, that imaging play a critical role in evaluation of patients with acute stroke. And the goal of imaging is to establish the correct diagnosis so that it facilitates a triage decision and also patient treatment, either thrombolysis or endovascular therapy. And for imaging, there is 4 points of critical evaluation, which is first, exclude hemorrhage, because if there is hemorrhage on the CT, you know that the management will be different. And second is to establish the infarction. And as we know, the acute infarctions, we don't see it on CT. And then acute, we can see some sign changes, is it subacute or chronic? And that also is very crucial for decision making for both IV thrombolysis and also endovascular therapy. And third is the arterial occlusion, and the CT, we should be able to tell, is it a large, is it a medium, or a distal occlusion? Because all that will take to your management. And lastly, we need to exclude what is not stroke, because as we know, the management is different. I would like just to come back a bit in different trial that Dr. Aruna mentioned earlier, so that we understand where we are today on stroke management. And so that we can implement a personalized medical care to our patients, because it's not everyone who stroke will be treated the same way. As we know, time is brain, and that window varies, so we have to know exactly what we are doing. So that will be our first question. You can answer on that app that you have. So what imaging for acute stroke? There's only one single best answer. Patient comes to you with stroke, so is it for CT brain pre and post contrast? You can start voting, just select your answer. Is it CT brain uncontrasted? Is CT brain uncontrasted? CT angiogram, CT perfusion, MR brain uncontrasted, or none of the above? Okay, so we can see that 68% of our audience choose CT brain uncontrasted, 20% say CT brain pre and post, only 4% for all that series of imaging, and 0 for MR brain. So the correct answer is CT brain uncontrasted, CT angiogram, CT perfusion, and MRI. Why I'm saying that, we'll go through that now, because I want to bring that perspective to you so that you know that you can do all that in acute stroke. It's not only the CT brain pre-contrast. Okay, great. Yeah, so meaning that you can do all that examination, but you have just to choose which one to start with, and what you want to have as answer. Okay, so now we'll look at 5 evidence-based guidelines, and then to understand which imaging is the best for our patient stroke. In 2015, there were 5 trials, as named there, and they look for the benefit of endovascular treatment for patients with large vessel occlusion for the anterior circulation within the first 6 hours. And the criteria for selection was moderate to severe stroke deficit. We heard about the NIHSS score, so it should be above 6. Absent of widespread established infarction on brain imaging, and there also aspect score of 6. We'll talk about that just in a moment. And then the occlusion of the carotid terminus or proximal MCA. They said here on this trial, they use both CTA and MRA. And as a result, these 5 RCT have shown that endovascular treatment is the standard of care for patients with anterior circulation large vessel occlusion, which meet the above criteria. And then as per the guideline, this was now set as standard within the first 6 hours that you have to do this. And in this category of patients, advanced imaging is not necessary, meaning that perfusion is at other things. And here is just an example. The patient with large vessel occlusion, what you can see is the carotid terminus, it's occluded there. And with first pass of stent retrieval, we managed to recognize the anterior circulation. And then on the second pass, the whole MCA is also recognized. So second evidence is in 2018 now, 2 study as well. Now here you can see that the window from 6 hours, large vessel occlusion, now we extend to up to 24 hours from the last time we knew about the stroke. And on the late window trial, now we have to use advanced imaging technique for patient selection. So that means that patient come to you, you should say, no, only CT to exclude hemorrhage. No, you know that we are in that 24 hours period now, we have to add more imaging so that you can define the time. And then you can do CT perfusion, you can do MR perfusion. And then that's include the evaluations of the core volume of the infarct. And nowadays we have got all AI automated software that can give us that estimation quick in the CT. And the trial, so the first one, the dawn, you can see the time frame there is 6 to 24 hours from symptom. And the volume was about 51 ml for the core volume. And the second one even went higher up to 70 ml within 6 to 16 hours of symptom. And then this trial has shown that level 1A evidence of benefit of endovascular therapy in late time window. But let's remember one thing, advanced image technique. Now, that's a second question. What is the best imaging for wake-up stroke? It was spoken earlier on. Someone wake up, they got stroke symptoms. Is it CT brain? Is it MR brain? Is it CT brain post contrast? Is it ultrasound brain? Or all the above? Only 2 voters. Where is the others? Okay, 11 voters, 16. I'm happy that this one you get it right because you listened to the previous talk. It was all day. Is it? Okay, well done. So MR brain is the imaging that you have. So now you see that depending on the window, depending on the presentation, you have to choose the imaging. It's not like everyone has to go for CT uncontrasted. Now, this is the third evidence guideline. And here we've got 2 major trials, which one is 2018, the wake-up trial, which look at the randomized use of IV thrombolysis. And it's 2019, the second trial also looked at IV thrombolysis. You can see that both trial is just a time difference. One is above 4.5 hours, while the second one went up to 9 hours. And they safely say that you can use IV thrombolysis on this patient if you use advanced imaging technique, because then you can define clearly the infarct volume, the tissue at risk, and then you can treat your patient. The fourth evidence-based guideline is, we have spoken about the anterior circulation. Now we're looking at also the posterior circulation. There are no proper guidelines about that. But 2 recent trials have addressed that. And also they have established, first of all, let's put the time period, time window, 6 to 24 hours. The NIHS above 6. And then the aspect score, because now we have modifiers for the posterior circulations, also above 6. The second one, the attention trial, both of them look at the basilar occlusion, but the time window was 12 hours from the onset. And here they went a bit higher with the NIHS up to 10, and same aspect score. And this guideline established the use of endovascular treatment in vaso-occlusion with good result. And this will be also now implemented as a new guideline. And lastly, the last evidence-based trial, now we're looking at the large core infarct. So if you got those large core infarcts, is it safe to traumatize your patient? Is it safe to use endovascular treatment? 3 trials have established level 1 evidence, and we'll see what they use for triage. One use MRI, the second one use CT, the third one use also almost in 85% non-controlled CT. And all of them have got almost the same aspect score between 3 and 5 and different in volume of the infarct. But all 3 provide evidence that endovascular treatment in large core stroke in anterior circulation is safe and more effective than best medical management alone. Looking at these 5 different trials, you can understand that the imaging of stroke is quite complex. It's not only one single thing. So you have to apply it to the patient so that you can give them personalized medical care and you can use the proper imaging for that patient. That leads us to our third point, which is the imaging paradigm. And we know that CT is the workhorse for emergency stroke, because from the time that patient arrives into your emergency or casualty, that patient can be transferred straight to CT. And CT does not need a lot of things. As they come with the ambulance, the family, the porters, everyone can go into the CT room and we measure the patient quickly, establish hemorrhage or not, we can start thrombolysis there. But with MRI, we can't do that. Just got high sensitivity, especially for DWI, and for acute stroke, that's the one to do. But we have to screen the patient. You have to know the patient has got pacemaker or not. Is there a clip that will move aneurysm before? Is there metal in the hip that if you put them in the magnet, it can dislodge? The people surrounding the patient, are they safe going to the magnet? All that will delay imaging. That's why we don't use MRIs first. But if you select your patient properly, then we know these ones are for MR. We can then prep as the patient are coming to the hospital. You can do all that questionnaire while they're being transferred. So regardless of the modality that you use, you have to streamline your protocol. That means that you understand what you are about to do. So anticipate all that so that there's no delay. When the patient arrives at the emergency, the time they go for imaging, all that should be streamlined. As it was said earlier, even ask the EMS services to do what they should do. Your blood, your clothing, they can do it as they're coming to the patient. So let's look at CT. For CT, we have got the non-contrasted one that we do usually without contrast. Then there is a CT angiogram for both brain and neck vessels. Here, read my lips, it's CT angiogram, not CT post-contrast, because we get that often. Stroke, CT, pre and post. There's no post-contrast. We need to do a brain uncontrasted, then we do an angiogram, because we need to look at the vessels. Because if after acute stroke, we don't see the occlusion, the angiogram will tell us which vessel is occluded. And then we can now do advanced imaging, which is now CT perfusion, if available. How many have heard about CT perfusion? How many have requested for it on their form? How many know that ERAD has got CT perfusion? So we have CT perfusion with a new scanner. It's automated AI. So you ask for it, we do, and then quick. Even for the aspect score, I'll show you examples where you ask for it, the machine does it for you. So for non-contrast CT brain, so this one, we just scan the brain without any contrast. Usually it's the first study that we do. And the aim of this study is to just exclude hemorrhage, because if there's no hemorrhage, we know thrombolysis. And what we can see on imaging varies from loss of gray-white matter differentiation. We can see the changes in the ganglia, insula, and all that. But the limitation of CT, I think I've said it, is just that early impact. Dr. Nana said your diagnosis of stroke is clinical. So if you are sure that it's a stroke, even if the CT is negative, you know that you need to treat that patient. You should not wait for changes on the CT. So, and then when you have got the patient, usually elderly with small vessel disease, or have got previous small infarct, the CT become a bit obsolete. You can't know, where is the new lesion? You can't tell. Second point on the CT, uncontrasted, is your aspect score. The aspect stands for Alberta Stroke Program, early CT score. And we have seen that in all the guidelines, that's what they're using now. To triage your patient, to decide treatment. So it should be in your common language. You should ask for it if we don't give it to you on our report. And then we know that higher aspect score associated with better outcome following stroke treatment. And currently we have got automated ones. I've jumped number 2, 3, and 4. No, this one I've said it. Number 2 and 3, we'll look at an example. Then I can explain to you how it works. So this is one of our own images, a 56-year patient with CVA with left hemiplegia. And then that's how his aspect score look like on the CT. And if you read, you can see that the machine is telling us, we don't have to think. It says 10, is it? So it says the score is 10. So it's a normal scan, is it? There's no stroke, no treatment, patient go home, is it? Clinically, there is left hemiplegia. So there's stroke, even if the aspect score is normal. Now, let's look at the aspect score. The aspect score, when we evaluate the MCA, and then when we're looking at the MCA, we're looking at 2 levels. The first one is on the basal ganglia level, and the second one is just above that. It's on the supratentorial, above the tentorium, basically. So if you have to count, you can see 1, 2, 3, 4, 5, 6, 7. Then you go above 8, 9, 10. So that's your total score. So that's normal, 10. For each area that is affected by the impact, it's -1. So if this patient, for example, we see that there is an impact here, and there's another one on that. So that 2, his aspect score will be 8. And then if there are more, then it will be 7, it will be 6, and all that. We see that most on all the trial that I mentioned earlier, the 6 was like where they stand for. So if it's 6 above, you are good to treat. So these things you should ask from us, radiologists. If you don't give this, take your phone and call me and say, but where is my aspect score? We should give this to you on every stroke patient. Now, to finish this case, because the machine says it was normal, but the radiologist says it's not normal. And just want my mouse again. We can see that this patient has a pontine, a brainstem lesion there. And that was the cause of his left hemiplegia. And you can see it's a hypodense lesion, so it's an ischemic lesion. This patient was treated fast enough because everything was well established. And after a week, we just assess that again and see. That's the core impact. You can see that it's almost the same volume that we had on the CT. Hasn't changed much. So this is a DWI, the diffusion weighted image. This one is a ADC map. It says that this lesion is doing well now. There is no more absence of cellularity, because now it's becoming more T2 bright. But look at on your flare, because we'll talk about flare later on, and your flare shows you that the lesion is there as well, but it's not bright as you have it on the DWI. This lesion is what we call flare match, because you see the lesion on the diffusion, you see it on the flare as well. Because when we talk later about mismatch, you understand why we mean by mismatch. So on non-contrast images as well, so we talk about the aspect score for the anterior circulations. Now I showed you that in the guideline now they apply the aspect score for the post-circulation as well. And also with CT, we can identify the site of occlusions. Either we have got interarterial thrombus, which usually it's hyperdense. We see that on the report. We talk about hyperdense MCA sign, hyperdense M1 sign. So we'll tell you where the lesion is. And other location, as I shown you on the previous example, for example, patient had normal cerebral hemisphere on the CT, but the lesion was in the brainstem. So that's why CT can give you all that aspect. And again, it's a fast imaging. Patient spent 30 seconds in the scan. We tell you what is there, automated response and all that. Now let's look at CT angiogram. CT angiogram, we said you need it for large vessel occlusion. You've got a hyperacute stroke. Your non-contrast CT is normal. While patient is still on the magnet, you give your thrombolysis if you meet all the criteria. We continue with imaging. Patient don't get transported from the CT, go to the ward, then come next day for a angiogram. No, it should be done there, what a day. So we do the CT angiogram, and after that pass of contrast, we do a CT perfusion as well, because it's all in one injection. Patient leave, you got all the information about the occlusion, and then for the angiogram, so we image from the aortic arch up to the vertex, so that we can include all the vessels. Because If, for example, you want to do a non-endovascular treatment, you need to know if your carotid are parted, because that's your tunnel you're going to use to go and remove the clot into the M1 segment. And if a lesion is on the same side of your intracerebral occlusion, that's why we talk about a tandem lesion, because if you start asking for this imaging, we're going to give you all this jargon, radiological one, you should get used to it. So we tell you that the patient got two lesions, one into the carotid and one into the intracranial. And now is debating in the literature now about talking about, should we also consider the M2 as large vessel, because it has been shown that those occlusions as well can also give you large impact. The angiograms, number two, apart from the side of occlusion, the angiogram also tells you about the collaterals. And that is on either side of the sacrophyllus, and it tells you how that infarct is perfused. And we have seen that clinically. I think you yourself have seen that when you're the patient with an infarct without not even thrombolysis, but the patient recover. How? So if you've got good leptomeningeal collateral supply, usually there's good prognosis for the patient, the recovery is also good, and there is small infarct volumes at the end, because the patient can get supply from the other side. Now, if you've got a poor collateralization, what happens is it's a slow, it's a fast progressor, and then you can also have large infarct, and these are the ones that can bleed later on. Patient was admitted, but then later on, didn't have hemorrhage on the admission, deteriorate, you repeat a CT, there's an hemorrhage. And for grading of this, it's quite easy. We just compare with the normal side. If it's much, it's good. If it's less than that, it's moderate. Then if it's less than that, less than 50%, we say that it's poor. And all this as well, you can do so nowadays with artificial intelligence. That means that there's no waste time, no time wasted in the CT. Third on CT is your CT perfusion. This is now where you want to know more about your patient. Patient can have a normal CT uncontrasted. Then when you do your angiogram, you see an M1 segment lesion. Then when you now into that brain further, you do your perfusion. Now, perfusion will tell you what is the size of the infarct, and that's what's called the ischemic score itself. And then what is the tissue at risk surrounding that? That's your penumbra. That's the tissue that you can save if you start early your thrombolysis, or if that patient goes for mechanical thrombectomy, because that tissue won't die. You save it, and the patient will have less complications and less disability. And again, this is done quick in CT, heavy contrast. We have got now all this automated process, AI, and then you got your answer as well. So there's no time wasted. Let's look at an example of that. This is a patient with 77-year-old wake-up stroke. So we don't know when that happened. And according to what I got from the literature, they said 12 hours later that the stroke happened. If you look at these images, I hope you have understood this map we told you about. If you look on the gray-white matter, we can see that this area, the head of caudate, and that part of the putamen is affected. That's what's in red. So we have got 2 points. What is the aspect score here? 8. Good. Then this is just uncontrasted scan. If we look again, what do we see? There's an hyperdense M1 segment there. So there's a clot. And this patient had a CT angio, and then we can see that clot nicely because it's not filling up. Then the patient had in red, we see the core, which correspond to what we saw on the uncontrasted CT. And the green is the penumbra. So that tissue is also at risk of infarct. If we don't do anything, that all tissue will infarct as well. Then this patient will have severe damage to his brain and will be disabled and all that. So just to say that you can use all this for advantage, you can know how to treat the patient fast, and also you can prevent more disability. A second case, also for perfusion, now that you are an expert on that, because now you can read all this, that's a normal CT, is it? There is nothing. But when you do the angiogram, it says there's something. This is a 76-year-old male with, they say it was witness, so witness stroke onset. And So we can see that we have got an obstruction on M1. When you do your angiogram, you confirm that, you do mechanical thrombectomy, it's open up. Quick interventions, the patient recover. But as we said, automated AI, yes, AI can replace radiologists. Yes, no, I don't think so. So why? Now, let's look at this perfusion map. It says this is all the core, and this is the penumbra. Patient was treated quick enough, and this CT was done, I think, 24 hours later. Still normal, is it? Normal. But your perfusion map showed you something that, yeah, it's a very, very, very bad. In fact, why? The reason is this patient are just good collaterals, is it? That's why, and also good intervention. First one, recovered 24 hours later, still nothing. And this MR was done, let me give you more history there. The MR was done, they said, if I can find that, 6 months later. And if you look at that MR, it's still normal. So this patient came in with a stroke, was treated adequately, and left like nothing happened. But that again is when you combine all your imaging, but you have to know one thing as well, that imaging can tell you, automated things can tell you wrong, give you wrong information. That's why you still need the radiologist to look at that and say, listen, it says this, but you've got good collaterals here. So what that map is saying, let's just leave it alone. Now, let's talk about MRI protocol. I know that most of you in the audience don't want to do MRI in stroke, is it? Who ask MRI as the first line when you got a stroke patient? No. Okay, no one. So MRI is a good tool. As I said, the only problem is screening of that patient, safety, because that's the magnet. We need to know that the patient is safe to go in that magnet. Sometimes they come with all these intubations, here, all those tubes. You can't push them on the magnet. You push them in there, the magnet pull everything. And then it's quenched. We can't scan the patient until we sort that out. So the DWI, we scan the patient only for 30 seconds. We get the answer. 30 seconds, not 1 minute, not 5, 30 seconds will tell you there is an acute stroke at that level. Your flare, okay, one thing. The DWI is positive in 20 minutes after the stroke has happened. That means that when we see all these negative CT, your WI will be positive. The flare now become positive after 6 hours. So if someone wakes up with stroke, we don't know the time. What imaging are you going to ask for? If you want to thrombolyze the patient fast, just for MRI. We do the WI, do the flare. Just these two sequences will tell you. If the flare is normal, there's a lesion on the WI, will tell you this stroke happened. The patient meets all the criteria. Then you have got other things you can do. So that's what we talk about, the DW flare mismatch. So a lesion is on DWI, it's not on flare because 6 hours hasn't elapsed yet. But even after 6 hours, the DW and flare will tell you you've got a large impact on DW. It's also big on flare. You know that this has been happening more than 6 hours. Or it's large and small. Then it tells you the core. So we can now determine based on that what is the core, in fact. And all this I'm seeing on DWI is a penumbra. It's something that I can salvage if I treat this patient adequately. Then what other things we can do with MRI is time of flight. This is a angiogram without contrast. That's an advantage of that, of MRI. Also, the ground echo or SWI, this one tells us hemorrhage. It's equivalent to the CT. So while you see blood, you can also see blood on MRI as well. So it's not that because you want to exclude hemorrhage, it's only CT that you can do that. Even on MRI, you can do it as well. And then you can also do it. MR perfusions, and also you can look at your T2 weighted to look at optional changes in the brain. So MRI advantages, we have spoken about it. I don't have to repeat myself. I think it's all clear there. But we know that on all the trial, it falls on the advanced technique. Choose it well when it's needed. And everything also with MRI nowadays is all automated. So I don't have to be there. I can be home and then patient goes in MRI and then my technician is there. They tell you, okay, the aspect it's this score, perfusion is that. Then you've got all your answers. Let's look at one example here. Now that you are the expert of MRI. So Patient with left hemiparesis, aphasia, and NHIS of 17. On the that's your flare sequence. Remember, that's your DWI. That's our core impact on DWI. And there is also another volume of changes there. If it does not restrict, it's not an impact. So we'll say that is just a penumbra tissue which is at high risk. Then we look at your flare. There's only changes here. Just that, minimal. Flare mismatch. This patient is candidate for thrombolysis. And then when you do this is your SWI or EMO sequence, we're looking for bleed on this one. There's no bleed. And your angiogram that we talk about shows that there is a large vessel occlusion. Your MCA is occluded completely. And then if now you do your neck vessels from the aortic arch all the way to the vertex, what you see is your common carotid artery becomes smaller because now there's only one vessel going outside your extracranial vessel. Your internal carotid artery is all occluded, tandem lesion. There you have it. We have spoken also about the MR disadvantage. We said safety, delay your imaging, patient triage. And other things, pitfalls is about UWI lesions because lesion can reverse due to time and also treatment. And also, if you don't interpret well your DWI, you can say this patient got a large infarct. Why don't have a large infarct? Because you don't know that you have the flare. So that's a pitfall and limitation for MRI. Now, let's look at how do we approach acute stroke imaging. One thing you have to remember about stroke, time is brain, so fast, and fast. That means that time is important as well. In our department, what we do is we give you that answer quickly when you need it. And activate all this once already you've got a stroke patient. So sometimes you see someone comes with a stroke request. Then they ask them, where is the patient? No, he's at home. I'm the doctor, I'm coming to book. You don't book for stroke imaging. So once you see this patient in your room, you see them in the casualty, you see the stroke, you activate the whole cascade of emergency. If you've got this patient on a scanner for an abdomen scan, we're going to put them out, take the brain in first and scan. So activate that. So it's fast. If you're fast, we are fast as well. We give you the information. And then we know what we want to do with the CT, exclude hemorrhage, large occlusion, go for thrombolysis and all that. And as we do for trauma, for stroke as well, we've got a fast initial primary survey, which allows rapid triage with the patient, and followed by the secondary one, which we can take our time and look at for other things. So the primary ones is things that we have spoken already: hemorrhage, infarction present or not, is it extent, aspect, occlusions, is it intracranial, extracranial, proximal stenosis, collateral status, perfusion defect. All that we can do it in one setup. Brain uncontrasted, angiogram, perfusion, give it all. Then the rest, secondary image survey, then I can sit, relax, and look at that, have my coffee, and then look at other things, what other things on the other part of the brain, then I can tell you. But at least I've given you all the primary information, then you can start your patient treatment. That's how we know that we can also do late thrombectomy up to 24 hours of their onset. That will not negate that we act fast. So time is brain, let's do that fast. When you go stroke code, let's do all the imaging in less than 10 minutes. And from the AMX collaboration, for every 9-minute delay in the onset of to reperfusion, 1 out of 100 patients will have greater functional disability at 90 days. And there's an inverse relationship between in-hospital treatment speed and functional independence, with reducing rate of good outcome as door to reperfusion time increases. So, Dr. Lona spoke about door to needle, door to imaging. What's your door to imaging? Maybe come back to as a question. Door to puncture, and ultimately door to reperfusion. So you have to be fast. Judge the time you see the patient, the time you give them your first dose of thrombolysis. What time? How long do you spend? And radiology is the cornerstone of stroke workflow imaging, but we have to be notified on time when activated cascade as things are happening. Don't wait until the patient reach casualty, then you call radiology. No, you should call them before that. And it's important also for radiologists to work on optimizing workflow together with all the imaging technologists, our radiographers, the stroke team, the neuro intervention team. So it's all kind of event that everyone involved should be notified. So that brings us to our last quiz of the day. What is your door to imaging or door to needle time in your practice or hospital? When you receive a patient with stroke, how long do you take to initiate your first treatment? Do you wait until they have the CT? Do you wait until the radiologist completes his report on the PAC system? It's emailed to you, then start treatment? So I see that most of you go for 10 minutes. Is that true? But that should be the goal, is it? So 10 minutes, you should do everything. Your imaging. If a casualty officer or a nurse is taking time, no, I need to find the drip, tell them, stop that. Let's go to CT first. We'll find the drip in the CT room. Why? No, we are there 24 hours. We work 24/7. If you call them before the patient arrive at the door, they will be there. Okay. We are selling toward our end. So now let's look at how do we optimize the imaging workflow in the acute stroke. So the first part of this first slide, we talk about the casualty or imaging department. So that's why, again, I think I'm repeating myself so that they say repetition is what? I know it in French. They say la répétition est la mère de la science. So I don't know in English. Let's say in English, repetition is the mother of science, something like that. So we start with a pre-alert from the EMS and ER stroke. Imaging team via a single paging system enable immediate action. So that's what we said about. Once you have that patient, involve everyone so they know that a stroke code is coming. Then you have your radiographer at the door waiting for you. But if you don't inform them, then on arrival, the patient is met by the stroke team and directly taken to CT or MRI. They say directly, not let me hear the heart sound, the mama. No, you meet the patient, you leave the hand. Oh, it's weak, face, droop, let's go to CT. You do the rest after. Then at the CT, we do the parenchymal imaging. Non-contrasted, we do that first to allow you to give your first dose of thrombolysis in the scanner. Then we do our contrast, angiogram, and the rest. From there, patient can now, if we need further imaging, we can continue that, but patients are already in the process of getting his treatment. And also one thing, no delay. Don't say no, I'll call the radiographer or the radiologist when I get my UNEs. In stroke, we don't need that. If the kidney is shut down, it's fine. You can have hemodialysis. But if the brain is shut down, not good, is it? Yeah. So now in radiology, we have got another optimized workflow. This, we follow it on daily basis. If we are informed, we're going to do all this for you, and we'll give you all the information. So this is more for radiologists, and then we just know that we have got also automated software, as I told you, can give us all this information. And for radiologists as well, we need to upgrade ourselves and use the AI because it's there for us to work fast and in a good, optimistic way. Stroke mimics, that is our last point. Almost 1/3 of cases of new focal neurology deficit can mimic stroke. And it's important that these are identified when the patient arrives so that we can differentiate it from stroke and give the patient the best treatment. And that's where now MRI has got its advantage over the CT to identify that. And the more common stroke mimic are seizures, migraines, posterior reversible encephalopathy syndrome, venous thrombosis, and brain tumors. So you come to the end. What are take-home messages? What's one thing that we'll remember from today's presentation? Time is brain. Yes. Let's act fast. Let's establish efficient workflow in acute stroke in our hospital, in the emergency department. Let's even know what we should do with stroke patient. It's from the nurse, from the porter, from the ambulance services, so that we can give this patient the personalized medical care. Because if we know when that stroke happened, we know what to do. If we don't know, but we know that we can use certain imaging to give us the answer and then give this patient best treatment, let's do it. And we know that there's best medical therapy that we'll talk about, the IV thrombolysis, but there is also endovascular treatment, mechanical thrombectomy, which is now the standard of care. So we need in Namibia to bring that. into our hospitals. We need to establish those services and have stroke unit. To my knowledge, there is no stroke unit in this country. So let's start somewhere. We can start with the basic, just time, fast workflow, thrombolysis, it's something. Then we can build on that. That's my references. I don't say any disclosure. The only disclosure is like, I work for ERAD. Thank you.
Thank you, Dr. Kabongo, for that interactive presentation. As we know you, you like teaching. And you make sure that we enjoy the experience. There's just one thing that we need to sort out before we welcome our last speaker to the platform to present. But if I can attest to what Dr. Kabongo said, time is key. And to the question, radiology is very tricky. After hours, it gets even more trickier. As Dr. Kabongo said, if the team gets called before the patient gets to the hospital, everybody will be there on time and everybody will be assisting the patient on time. But most of our requests always come when the patient is already at the hospital and we have about 10 to 15 minutes, depending on where you're staying in Walker's Bay, to get dressed, get to the hospital and screen your patient under CT and MRI. So if we have the correct protocols to follow, we can get quicker to the hospital to assist the patient faster. As we say, time is of the essence when it comes to these cases, if I can say so. Thank you, everyone, for being with us so far. Next, I'm going to introduce our last speaker, Dr. Emmanuel Thobejane. He is a well-known neurospinal surgeon and pain interventionist from South Africa and in Namibia, 19 years of experience in his field. He completed his Bachelor's of Medicine and Surgery from the Medical University of Southern Africa in Pretoria in 2003, and his Master's of Medicine in Neurosurgery from the University of Victoria in 2012. As a trained professional, his interest is mainly in pain management, but has grown, and it is with this that he has become a fellow of the Interventional Pain Practice at the World Institute of Pain in Miami, Florida in 2014. His areas of expertise lay in advanced cranial surgery, advanced spinal surgery, interventional pain management, spinal tumor treatment, minimal invasive spine surgery, endoscopic spinal surgery, as well as artificial disc replacement, to mention but a few. He is involved with postgraduate training in the Department of Neurosurgery at the Steve Biko Hospital in Pretoria, and is the chairperson of WIP, African Section, as well as the Pain SA Council member and member of the American College of Independent Medical Examiners, and is or was appointed as the MBIME Board Advisor representing Southern Africa in 2021.
Right, good evening, colleagues. Thank you so much, Aleta, for the invitation. On behalf of ERAD, we appreciate the opportunity for being invited. Yes, and of course, the warm introduction. Somebody might be fighting me that I think since the beginning of the year, I relinquished the chairpersonship Africa section for the World Institute of Pain to someone who's already also in Namibia, Dr. Eric Mansfeld. He's now the current president of the World Institute of Pain, representing the whole of the African continent in the world space. Right, I'm glad I'm the last speaker. I've already seen people refilling glasses. Give me the brain, I can always tell you if it's functional at optimum or not. They'll tell you in theater that we do open brains and see whether they are functioning. Then we erase some files and close it up. Having said that, let me thank the previous speakers, Dr. Loena for laying the foundation, as well as Dr. Kabongo for educating us with the imaging. On that note, we also have to, I'm gonna ask everybody just to, I don't know how you're gonna do it, to acknowledge there's a little boy who's growing up today, Dr. Kamenye. That's his birthday. We can just clap for him. He still remains short, even if you're growing. Right, there's gonna be a lot of overlap with a little bit of more emphasis on certain aspects. As Dr. Kabongo has said, that sometimes repetition seems to be the master. so that these things, they remain and impregnated in our heads. Disclosures, yeah, I've got none. Other than yes, I'm part of the team that is at Valvicia. We're going to look at some basic principles of management, a little bit of a note as to how should we approach a ischemic stroke. I think Dr. Loen as well as Dr. Kabongo has already touched on a crucial aspects, and they're all shied away from hemorrhagic stroke. I think they decided to leave it for me, and I'll definitely show you who I'm going to leave it for. And challenges on some of the implementations, and why we're struggling to implement some of the things that we ought to implement. Right, there's this phrase that you have seen it coming now and again, that time is brain. This almost emanates from cardiology, where they say time is muscle in the cardiac ischemic attacks, that for every little time period that it gets delayed, you seem to lose one of the most important muscle function on the heart, and as a result, you end up with a myocardial infarct. These are some of the things that we require for us to manage strokes. Number one, of course, be cognizant of time. I don't think that can be overemphasized. I had a patient who had intracranial bleed, referred from Sokov Hospital, or was it the Mediclinic? And you know, when somebody calls you to refer a patient, and I end up being the one panicking more than the person who's referring the patient to me. And immediately on the spot, I think it was 1 a.m. I'm like, no, doc, I need that patient now. And just like Dr. Kabongo said, activate the team. And when I said now, I estimated it shouldn't take more than 30 minutes for me to receive the patient. Already in my hospital, the ICU, the casualty were aware, theater team was in theater waiting for the patient. Somebody must open the file must find my patient in theater, not the other way around. Yeah, I'm standing here to say, no, at least the team did demonstrate that was activated. My anesthetist was here in 20 minutes from Sokop. That means she was faster than the patient. And the doctor, after every 20 minutes, doc, where is the patient? I'm not sure, doc, let me go and have a look. It means the doctor was not even with the patient. Yet you are calling us, and all of us are in theater. That for me showed that there's a big mismatch there. Awareness campaign. The more we talk about it, the better. People are going to recognize it. And Dr. Loena mentioned the NIH score. I'm not sure as to how many of our colleagues can actually score these patients. Those scores are there to guide our treatment. If you don't know the scores to where you are, you're going to have problems. That means we're not going to be able to address the patient's problem to the right medication. So that's part of the management. You got to know how to assess the patient. Early diagnosis referral, ischemic versus hemorrhagic stroke. And of course, we have to consider the differentials. I used to work in South Africa in one of the rural hospitals that some people will just admit anybody clinically stroke. You know, stroke means hemi. People just say hemi stroke. No, that's CVA, admitting the ward. Until you realize that down the line, actually the patient was harboring a meningioma. So I would like to emphasize what Dr. Kabongo is saying. If there's something that you cannot explain, please just image that patient. That's part of management. Image the patient. If people are having issues with MRIs or CT scans and so on, at least do document in your records that I would have wanted to scan, but Dr. Kabongo said no, because we are going to take you to task with it. In Namibia, it's still a little bit nice and cool and cold, but in South Africa, it's very huge with medical legal. And if you are going to mismanage one of the patients, make it difficult for us to realize that the problem was you. But if you don't do record keeping, we're going to find ourselves in trouble. For me, just to specialize as a neurosurgeon, my medical insurance is about 600,000 per year that I need to pay every month, not less than 60,000 Namibian dollars, just for me to be a neurosurgeon, and also the ops and guides. So that tells you with the medical protection that you are in trouble, especially if you don't document. Right. Again, part of management is time, the delays, and try your level best that you are not a stumbling block on the treatment of the patient. If you can pick it up, it's still not good enough. Get rid of it from your hands. Then so that the other people can hold the baton and run with it. You can see there that on the chart, the first block shows the centers that have got the capabilities of dealing with patients with stroke. meaning the center that you're going to refer to the patient to, they can actually do thrombolysis. That means give the medication to dissolve the clot, or they can mechanically go inside, put a catheter in the vessel, retract the clot so that the channels can be open. So if you are referring to a center that's got all those facilities, it delays the time management. In our literature shows that on average, it might take about 77 minutes, just over an hour for the patient to get help. This was done in Europe. You can see that standardized in all these things, that EMS alone, transportation, takes on average 35 minutes. So you have to factor that in. And then the second one shows the graph of the facility that they can do the procedures for the patient, but they tend to start with a classical form of imaging. Like Dr. Kabongo was already saying that 15 years ago, we used to know just CT as the main, but as the time evolves, now we need all these other modalities so that we can start expediting treatment for our patients. The MRI has been pulled in, the angio suit has been pulled in, all those ones, we now have them. So if a facility can do everything else other than those ones, then on average, you'll have to accommodate additional 42 minutes or so for those kind of things, because sometimes you might have to refer. If you're still going to refer to a clinic or to some small hospital that will require secondary referral, then you can see how much time we're talking about. So if you can identify stroke, you need to be aware of your area. Where should I send the patient to? And in that way, you'll be knowing exactly as to, let me minimize the delays. Again, that's part of management. Right, what is our objective in terms of treating ischemic stroke? Ischemia means there's reduced blood supply to essential part of the brain. We want to make sure that we recanalize that vessel, either through medical or through mechanical pulling of that clot. So we open up that vessel. If you don't open it up, then you are risking almost losing a larger area as affected. And Dr. Kabongo has mentioned the so-called penumbra or penumbra area there. That means that's a salvageable brain that should we act fast, we might actually retain some of the function of that tissue. We want to improve functionality and save life, but most importantly, whatever your intervention, you want to prevent hemorrhagic transformation. That's why they've got timelines. If you just want to do thrombolysis in all these patients, or you want to introduce a catheter there just to unblock a vessel, where there was a hole, you're going to have changed the whole thing into hemorrhage or bleeding. So it's a matter of balancing as to know when to do what and with what technique and for what benefit you want to achieve. This is one of the drugs that people use medically. I'm a surgeon, but I need them to use all these TPAs and so on so that they can liquefy the clot. You can see that the dose there is about 0.9. At least most people are working in ICUs and even at the emergency or even at radiology needs to be quite conversant as to what intervention should they do or call for help. Dr. Loena is here as a physician, they will attend. In some centers for us, when you're in South Africa, we've got the neurologist on board. So the whole team seems to be aware, but most importantly, the ICU team as well, to know how to move forward with this patient. In all the literatures that I went through, that's the protocol that they tend to use for them to say this has an effect or it doesn't have an effect. Of course, we can't overemphasize, seems to be working quite very well if initiated within 4.5 hours. But Dr. Loena also mentioned to say, there's no benefit of putting it in patients beyond those times, unless in hyper-selected patients with additional form of imaging, then you can say, yes, but in this one, I'll make a special case. But as a general guide, you want to make sure that you thrombolyze all these patients within 4 hours of having picked up that stroke. The question becomes, how practical is it in our environment that you can get a patient within 4 hours and then you do that? So that means awareness, 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 awareness all the time. If you're a GP, you need to have connection with your patients that they can call that, doc, my mom's left arm is not working. Don't say bring to my practice. Better say, let's meet that casualty. That's much better. If it's not stroke, you go back to your rooms. But if it's stroke, the patient is already receiving some form of attention. Thrombectomy, like I said, they introduce a catheter, either a balloon or a stent, or even some aspiration techniques. These are mainly mastered by cardiologists. They play quite a lot with the catheters in the suits, going there. Also, we might have to have a department, neuro-interventional people. I just like the more of clipping aneurysm mechanically as opposed to using catheter. Then most of the time right now, the clipping of aneurysms tend to be obsolete. People use catheters to go and balloon, to go and block, to go and stent everything intravascularly. And then the field of medicine tends to overlap a little bit more. Now we've got the interventional radiologist. Dr. Kabongo can go and learn how to retrieve all these things and perform these catheters. Similarly, if you are at a center for the cardiologist and you don't have anybody else with the expertise, then they can actually upscale their skill and then be part of the team to look after the stroke patients. This is mainly deployed within 6 to 24 hours post-stroke, that you can actually realize that thrombolysis might be contraindicated in this patient. That means go and mechanically pull down that clot from the vessel to try and open it up. It works quite nicely in large vessel occlusions. What do we mean by this? Dr. Kabongo has already demonstrated, especially in the carotid and the proximal M1 segments, advanced techniques into M2. Again, you can see on the pictures there that Dr. Kabongo has already explained. On the first picture, you can't even see any of the MCA going up. That's internal carotid. Almost it bifurcates there to anterior cerebral, then the middle cerebral, but you can't see anything beyond that. But through thrombectomy, then you are able to see some flow in those kind of areas there, and then you might restore some of the function for the patient. The European Journal has summarized almost this approach to say, if you have a patient who comes to you within 4.5 hours of the stroke, the whole idea is for us to push that patient towards thrombolysis as early as possible. If it's beyond 4.5 hours, then that means we need to go and retrieve the clot ourselves mechanically. The question is, can we offer that service here or not? So already that becomes the stumbling block. And Dr. Kabongo said that he's not aware that we have that kind of facility here. What does it mean? We need to go back, reinvest, and see whether can we offer our patients that tomorrow's going to be your mom or your relative, then we're going to have issues. But then again, I agree with Dr. Kabongo to say, previously, it's been almost 7 years now that this thing has been moved from over 6 hours at least to 24 hours, that we can still do something. But what is it that helps us is this advanced imaging techniques that helps us to say, okay, fine, it's not all lost. We can still do something. When you're at the peripheries, as long as it's stroke, people leave the brain, leave functionality, focus on blood pressure medication, not outcome. And that becomes a problem. It's just say, as long as you wrote physio form, go for OT and physio. That's not management. Management is to make change in the patient's outcome by you being there. There are lots of studies that have been done, randomized controlled trials, meta-analysis, a lot of studies trying to see what other medication, what other drugs can be comparative, give us the results there. Of course, that is easier to dose, easier to manage without causing lots of issues. And then they still picked up, like Dr. Loena said, that we do have several medications, but then again, it's still not yet standard protocol, but I think very soon they're going to be approved for us to make use of this universally. But the timelines remains key, the 4.5 hours preferably. From there, the next phase is for you to go and retrieve the clot and take it from there. Dr. Kabongo mentioned quite another important thing again, posterior circulation remains the problem. What do we mean by this? The basilar artery there, with occlusion, usually would like to say, okay, because it forms part of the so-called major vessel, you can go and retrieve there. But the studies have demonstrated that for some reason, patients with this kind of occlusion don't seem to do very well with a retrieval of the clot in that area. But then the key things for us to, again, try your level best to do the intravenous thrombolysis with those patients. You can extend it even up to 6 hours in these patients. But then again, since more benefits in patients that you scored at least more than 10, they will show you some favorable outcomes in these patients for you to say, that means you've got relatively nothing to lose per se. You go there, go and try and retrieve, and then you might find yourself getting some form of update. Certain things can go wrong with your intervention, either the thrombolysis or medication, or when you're going to retrieve the whole clot yourself there. The first thing, of course, is that you can develop intracranial bleed. You've got a patient with stroke, it's a hemi, you are trying your best to save that part of the arm or the leg, and then you end up with a patient who's dead from the bleed. Why? You've already passed the limit of opening up that clot. Now everything is just cashed. Or you're not monitoring your blood pressure. Or you've just done with your catheter, you went fine beyond, and you're having those kind of issues. Or you have just dislodged one of the clot to another vessel. Then you have caused another stroke for the patient. So while you are doing your interventions, you have to clinically monitor your patient for response. From the imaging point of view, we tend to see some of these complications much more often. That Dr. Kabongo will tell you that there's a clot, there's a new bleed, that when I look at my patient is still okay. I haven't added any neurological deficit on the patient. So about 13% of them you can actually ignore, but they'll be radiologically evident on the imaging to say, hey, look at 1, 2, 3, 4, 5. Then of course I'm the one with the patient. In as much as he can overrule AI, I can also overrule him on the patient. Then I'm okay. Access site, we're going to puncture those patients to try and deploy that catheter there. You might easily cause femoral AV fistulas or a groin hematoma there. I've seen patients that, like Dr. Kabongo said, that the key things, forget about the clotting and whatnot at that stage. You need to make sure that at least you aim for surviving or reviving the brain. And you might find yourself, if you don't do proper pressure control or you're having some other clotting issues, you might deal with some groin hematoma there that might be symptomatic. General anesthesia, some of the institutions will push in the patient to theater angio suit so that you can deploy the catheter. Sometimes it's much better to do it under sedation or patient who's semi-awake. When I was studying neurosurgery at University of Pretoria, we ended up having to abort sending our patients for angio suits because they go there, somebody's got subarachnoid hemorrhage, Jesus 15-15, or just have some drooping eye, go for 4-vessel or 6-vessel angio, comes back with a hemi. Okay, so and then until we aborted to say, we'll rather send our patient to private because we've got a lot of people who are still learning there and they mess up the brains of patients. So in the angio suits, some people will say, if a patient has got depressed level of consciousness or is restless, rather give the patient GA so that you can do the interventions because you manipulate the catheter in the brain of a patient, in a vessel of a patient. So a slight movement that is not controlled, you're going to have issues. But then there are problems with that, giving somebody GA or anesthesia. During intubation, your blood pressure drops. If it drops, you are losing your penumbra area. Why? Because you just made everything worse. And sometimes putting the catheter in the whole thing there, you can cause what you call vasospasm. Then the vessels just narrow. You lose that having dislodged or open up that vessel for the patient. So somebody goes there with arm paralysis, but now comes out with arm and leg. What does it mean? You've actually increased or caused the patient to have another stroke with your intervention, which might be difficult for you to see if a patient is under GA. But if the patient is awake and so on, you converse with the patient, you might be able now and again, lift up your leg, move your arm. You are able to monitor the patient clinically. How should you look after these patients once you are done with your thrombolysis or with a thrombectomy in the ICUs? You've got to make sure that you are still part of caring this patient. Don't just say patient has been thrombolized, that's fine, you are out of the woods. No, your management of the blood pressure in the unit is much more critical. And for me, we always struggled when we started coming here that our intensive care unit, I'm glad my intensive care doctor is here and the team is here. You cannot manage this blood pressure of this patient with an NIBP. You can't. Because every 15 minutes, you measure. You need invasive monitoring on this patient. So you don't want labile blood pressure. You want to control it at a certain level. If there's intervention, intervene almost immediately, and then you can take it from there. So we need those pressure pumps in the unit. The A lines must be there on this patient so that you can almost have a graph on the monitors. Then you know where did you start losing it, where did you start gaining it, because it can either mean blood pressure, change of neurology, or you shoot high, patient bled. Then you must go and rescan quickly and check. But if you are able to say, okay, no, here the blood pressure was low, that's why maybe my patient, the drooling comes back again. Let me pick it up. When you pick it up, the patient is improving. Then you know, I don't have to go and wheel this patient for scan. But if you don't have those ways of monitoring, then you're going to find yourself in trouble. And especially in private care, when scan, they'll tell you, no, doc, patients' funds are depleted, then we're having problems. Again, you must remember that whatever the stroke, whatever the intervention, that's primary insult to the brain. Our job as clinicians, we can't do much with primary insult to the brain. Our job is to prevent secondary insult to the brain. We must manage the edema, the cytotoxic edema that happens around the clot. We must also manage anything else that will pull us back or our interventions back. The blood pressures, the hyperglycemia, all those things, that's part of your care in that patient. But most importantly, in intensive care unit, we want ongoing neurological assessment so that you can tell us if there are problems, we pick them up, and then we correct as we move. So you are part of the treatment team for this patient with a stroke, hemorrhagic components. This constitutes around up to 15%. Dr. Loena studies that she looked at, it was about between 10 to 20%. So still in keeping. She was leaning more towards the American guidelines. I'm leaning more towards the European guidelines. So that's pretty much, they speak the same language. Again, we see quite a lot of these ones when they come to us, and somebody will call you, but you realize that I usually don't have that much of enthusiasm. The moment I pop and have a look at the scan, like, okay, oh no, this one, I might not have to do anything much about it. There's a big trial that used to happen in 2011, 2012, stitch trials. There was phase 1 and phase 2. Again, they were trying to assess, is there any role of surgery in these patients who develop spontaneous intracranial hemorrhages? Yes, the majority of them would be secondary to hypertension or uncontrolled hypertension. That means we'll give you what you call direct stroke. But then again, we've got other hemorrhagic lesions that can present more like a stroke. But actually, that means it's a hemorrhagic transformation or arteriovenous malformation, ruptured aneurysms, or some of the metastatic lesions that can actually bleed. So that's why we must make sure that we assess this patient properly. And once you see something, hypertensive bleed tends to be localized mainly around the thalamus area and so on, or the basal ganglia, will rupture into the ventricles. If you see blood in the fourth ventricle, we usually say that's an omnima sign. That means the chances of survival for these patients are almost close to zero. If you see blood in the fourth ventricle, we actually don't expect to gain anything back from that patient. We ventured into the stitch trial, which was coordinated in Switzerland. I think in South Africa, we are the only center in Pretoria where we actually submitted some patients on this study as well. We had a head of department who was very enthusiastic about hypertensive bleeds, and we had to focus on them. Then we started changing the criteria to say, let's not look at the whole generalized basal ganglia bleed. Let's look at, can we make a difference in patients with lobar bleeds? That means focal cortical bleeds on the surface, 1 centimeter at least, with a volume of about 100, to try and manage the intracranial pressure, reduce the volume, and then see whether these patients will do very well or not. Then we take it from there. They excluded some of the patients with interventricular extensions because we already know that those don't live in quite very well. But then again, we have to correct. Once you identify the patient, you must operate within 12 hours to see whether are we going to get any outcome or not. You can see that these are tedious, especially when you are in Africa. To get a patient from here to almost Windhoek, yeah, and to get the patient in theater within 12 hours in state, it's almost, yeah. So I think we screened over 300 patients, but only 10 were eligible to be added on the study. And you can see purely because of the times that were almost pulling us out. This is what we're trying to look for. Lobar bleeds, if you look at this, you realize that, oh my God, it looks like maybe if I go and remove that, we'll see whether we'll either to decide to manage this patient conservatively or go and remove that clot to buy some space in the brain for the patient. Will it make a difference or not? As opposed to this patient will automatically exclude from our study. And indeed, but then despite everything else, this was the stitch 2 trial that looked at those lobar bleeds. The only unfortunate thing is that even removing that clot, it was much better just to leave the patient alone. Someone tried to look to say, maybe when we do craniotomies, it becomes big operations. Let's rather do smaller operations just so that we can just aim for that clot, suck it out, and take it from there. But then again, even the so-called MIS, people are still hopeful because it's very difficult to look at that scan, just ignore whatever that bleed, patient deteriorating. Sometimes the pressure is too high. You don't know, is it the pressure in the brain or is it the initial insult on the brain tissue itself or not? And some of them have also even looked at the role of intracranial pressure monitoring on this patient, but we still struggle to correlate the clinical findings with the measuring of these pressures. That tells us that spontaneous intracranial bleed behaves much more different than traumatic bleeds. So there's much more that we still don't understand as far as that is concerned. But whatever surgical intervention is concerned in spontaneous bleeds has limited role, other than if there's any structural lesion, be it from a tumor, be it from arteriovenous malformation, be it from ruptured aneurysm. Yes, we can go and make a difference. But the hypertensive ones, I'm glad to present to you to say you don't need to wake a neurosurgeon up. It's been almost just over 2 hours talking about stroke and what we can do. The question is, are we enabled or are we empowered to make a difference in these patients moving forward? There are some challenges that unfortunately we find ourselves in. Some of them are just regional. If you look at how sparse Namibian population is, 3 million, for you to set up a unit, so-called stroke unit, strictly speaking, guidelines with the facilities that you can do thrombectomy, you need a minimum of 4 to 6 skilled people to work on the patient, to wheel in there and have an angio suit so that once you are done, you can check whether you've managed to recanalize or not. Because Dr. Kabongo can do it in CT scan and show the vessel, but when you do thrombectomy, you want to make sure that did I manage to open the vessel or not? You can't do it at a scanner. It must be done in an angio suit. That means we need to have an angiogram in theater, so that once I pull the clot, we pass contrast to see did I manage to open or not. Then that's how we are able to get those pictures. I can't go to theater, pull it out, push back to the Kabongo, and then bring back, and then. So you need a facility that has got the whole angio suit. That when the patient comes from casualty, we are going to image and make a diagnosis while we are treating. That's what needs to happen. The question is, can we achieve that here or not? I had some gravy train that they are establishing an angio unit at Windhoek. Maybe we must just try and engage much more and see where can we come as well and see how to optimize the referral for those ones. The facility with capabilities of thrombectomy within 24 hours can actually make a change in the patient's outcome and save a life. Again, the other thing that might be a bottleneck here is the provision of healthcare in our country. What model are we using? Most of the guys are in private sector, but most of these patients are in the state. And then we find ourselves that to get a patient there, these hospitals are much more close to each other. But somebody will die from a stroke there while the skill is just next door. Then that means the units need to have what we call MOU, some form of working together for the better outcome of our patient. But for as long as we don't establish that, we put money as a factor, we're going to have issues. But then at least we need to look into that as well. Challenges with regard to the facility, again, to set up an angio suit, it will cost Valvicia a massive amount of money. The question becomes, from investment point of view, and I say, is this proper return of investment or not? How many stroke patients do I treat per annum? If you only treat 2, then it's not worth it. It's not worth the investment. But then again, you can't put money on the life of a patient. But in private, unfortunately, we have to monetize you. Otherwise, we're going to have problems. Why? The resources are limited. You can either afford or you can't afford. Not that we can't help you, but let's go to a facility where we can help. Resources, interfacility as well, and collaboration. Once again, I don't think we've got a cardiologist here. If you do, it's visiting. Even if he's here, do we have the equipment? Do we have the resources to enable? Because somebody might be here, but you need to have things that are going to enable the intervention that you want to deploy on a patient. The big challenge still remains here. Like I made an example with a patient from Sokop. It took 1 hour, 10 minutes, is the memory, for that patient to arrive from Sokop. 1 hour, 10 minutes. Somebody GCS of less than 8, admitted to a ward, not tubed. When he arrived here, she has aspirated. Yeah, so all those little things, it means even if we want to blame the ambulance guys, but our own people are having issues. And sometimes you find that the guys of the ambulance, they want to drive and they get a tire puncture on the way. So again, what does it mean? Even our emergency evacuation might not be fully optimal to function. And then the area where you can contribute ourselves as clinicians, we can't overemphasize. You cannot, I'm happy with the polls that Dr. Kabongo is doing, that we are trying, we are wishing. By the time to evaluate the patient and send for scanner, we say we want to limit at 10 minutes. I hope we can practice that. Why? We can pick it up quickly, make a diagnosis, this is stroke, leave the drips, leave whatever. Some patients say, no, but maybe I'll see tomorrow, doc, if I'm getting better or not. Tomorrow means beyond 24 hours, then it's pointless. When I say go to hospital, doc, now, no, man, I can still use this hand here. I've seen patients do that. Why? A hand that is paralyzed is not a dominant hand. He can still ride, he can drive. No, doc, let me go on my business and I'll come tomorrow. And then we're having issues there. Imaging, thank you so much, Dr. Kabongo, for educating us. And also, we're having a facility that we're not optimizing fully. It's meetings like this that will enable us to say, hey, we can ask for this, we can ask for this. As for me, because I'm a neurosurgeon, I walk into the unit and I demand. They even scan my dead patient because I don't want to ventilate somebody who's dead in the ICU. That's a waste of resources. If I make a diagnosis of death, I want to finalize it now. Please do an angio, no blood in the brain, patient gone. Let's go and lay you so that we can use the ventilator for somebody. Intervention, again, needs a skill. That means we must go back to school, go back to other units where we can learn these techniques and come and deploy. But then again, you can learn a skill. If you can't use it, it's pointless. Or use it once every 6 months. You're not going to master that. You're going to be the one, instead of pulling out the clot, puncturing the vessels. And I've seen that in practice. Support, we need collaboration. We need to know who's got the expertise to do what, and then we can partner. ICU must be on board, casualty must be on board, GPs must be on board. There must be some pamphlets or fast, like Dr. Loena said. Patients sitting there in the waiting room, there's something that educates them how to pick up a stroke from their mother at home so that they can call. All those things will try and move ourselves closer to the interventions that we can offer these patients. And with that, I think that's the last slide. Thank you.
Thank you, Dr. T, for the straight and direct presentation. I hope everybody appreciated his input on the topic. We have reached the end of our presentation. We are grateful for everyone's attendance, for making the effort to be here tonight. Up next, we have our Q&A session. We have a first question from our online audience. I don't know who, it's probably mostly directed maybe to Dr. Kabongo. I'm not sure, but whoever can answer for us. The question is, despite MRI being valuable in the investigation and management of stroke, is it possible to diagnose negatively for a stroke condition? If yes, what is the percentage?
I think that question was answered as we went through the presentation. We said MRI is part of advanced imaging. You can use for triage, but it's cumbersome. You have to first establish safety for the patient. So I don't know any percentage, because all the randomized trial I looked at, they are using an advanced tool and also to support what you have first on your CT imaging. So I can't say there's a big number, 50% or what. No, there's no such. And we know that MRI has got its own advantage for wake-up stroke. And also, you can also, for your mimic, it's also a great tool to use. So, but a percentage, I didn't find that in the literature.
Any audience questions? The teacher said now the message is, I think, very much clear from all three perspectives that we've heard tonight. I'm just going to announce it now. Certificates will be available a month after the event. Important, if you haven't registered on our register outside, please do so, because it's vital to have the relevant information that I need to create the certificates. The recording of the event has been recorded and live streamed via Zoom. So the recording link will be forwarded. If you have completed your email address clearly enough, I will forward you the link to the recording, and then as well hard copy of the presentations to anyone that's interested as well during next week. Yeah, just to give us enough time to go through the recording. So we thank everyone for being here tonight. We appreciate your presence. Our next event is in June. It will be presented by our visiting interventional radiologist, Dr. Andrew Lawson. The topic, novel endovascular therapy for benign prostatic hypertrophy and knee osteoarthritis. We will announce again, moving forward with the specific dates and times that will be held at. But as informed, it will be presented by Dr. Andrew Lawson. There will be the next CPD event will be a co-presentation, but will be held by the Wilbicha Hospital through Sister Janssen, presented by Dr. Miller, and then a bit of input from Dr. Kabongo as well on the topic that he will be presenting on. The topic to that will also be announced in due course by Sister Janssen. Everybody should have gotten a feedback receipt on their tables as well. So if you could complete it, just drop it in the box outside as well. As informed, we have extra referral pads outside for your practices. If you finish your referral pads for ERAD, you are more than welcome to take for your offices. And we hope you had a good and informative session. And close remarks. Awareness is key. Speed is key as well. Time is brain. Time is brain. Mostly important. It involves it all, includes it all. We thank you once again, and we'll see you at our next event.